Hi everyone, so I'm Matt Somerville and I want to welcome you all to our very first online departmental research seminar series. So today we are very lucky to have Dr. Amy Harrison speaking to us. So Amy's research focuses on understanding the cognitive and social emotional factors that maintain eating disorders. So Amy is also a practicing clinical psychologist, and she's worked at a number of specialist child and adolescent eating disorder services. And today, Amy is going to be talking to us about her Medical Research Council funded project that explores how decision-making in childhood and adolescence might relate to the development of eating disorders in adolescence. So, the format, I'm still admitting people, the format for today is Amy is going to speak for around 40 minutes, I think, right, Amy?
Yeah, that's the plan.
And after that, we should have plenty of time. We're planning to go up until about 1, so should have plenty of time for questions and answers and discussions afterwards. I think I saw Marta here before as well, right? Marta's on the project too, so she, actually, there she is, just joining now. Might be able to jump in too. Okay, and we are recording the session. We will, if somebody reminds me, I'll stop recording as soon as Amy finishes her talk, and that's when we'll begin the question and answers and discussions. Okay, so over to you, Amy.
Thank you so much for giving me the opportunity to share this really quite large body of work. I've given a number of talks at conferences and to different kind of carers, professionals, patient groups on the sort of different aspects of the study. And this is the first time I've been able to speak about the sort of project and study in the whole. So I'm really, really pleased to be here and being able to share what this new knowledge that we've gained from this work. So this project is funded by the Medical Research Council in collaboration with the Medical Research Foundation, and it's work that I've done with my slides are not moving, with Professor Irini Fleury and Dr. Marta Francesconi. So I know Marta's here today, and perhaps she'll help me answer some questions at the end. And we're really proud of this collaboration. I think we've really brought together experts in epidemiology and developmental psychology, in eating disorders and neuropsychology. And we've really, I think, advanced the field. So hopefully that's what I'll be able to share with you today. So the talk will sort of follow a path roughly like this. I'll first share with you some of the unanswered questions in the field and explain to you why decision making is important in eating disorders and why it's relevant. And then I'll talk to you a bit about how we've tackled some of the gaps in the literature and the gaps in our knowledge, and share with you our findings, and then have some space to speak about what these findings mean and what next. And we'll have a nice discussion at the end, and I really value your feedback and your ideas as well. So why are eating disorders important to study as an illness? And what are some of the challenges that people with the disorder face and society as a whole? And unfortunately, these are very serious psychological illnesses. In fact, they're the psychological disorder that is responsible for the most deaths. And they typically start in adolescence, and for many, they will continue into adulthood. And about 20% of people will have this very severe and enduring form of illness, which can last decades. Some eating disorders are associated with being severely underweight. Most people with eating disorders have average or overweight, and kind of many people with eating disorders, particularly those that have very underweight illnesses, also experience physical complications, and that's often what gets people into hospital. And if we look at child and adolescent services, eating disorders take up the most beds for these patients. Eating disorders are associated with a very poor quality of life and social adversity, which is about the same as experienced by people with schizophrenia. So often the public have a view of eating disorders as a kind of phase that happens to a certain person. Usually the sort of stereotype is a kind of white middle-class girl going to an all-girls school. There's some recent research from a review in the field that shows that socioeconomic status and eating disorders are not associated, so they can affect people from any background. They do not pick on any particular group. And they're also associated with very significant care needs, and that's not only from services, but also from the family and other supporters. And that's because we have to eat several times a day, and that's a very stressful thing for a person with an eating disorder, and they'll need a lot of support, but they may also need support with other behaviours. And often we find that people miss developmental milestones, so they perhaps miss completing their school, or moving into the workplace, or going to further or higher education. So they can often need extra support, sort of catching up on that a bit later in adulthood. We know that the eating disorders are very costly, and Beat, the eating disorder charity, has produced some really useful figures on this recently. We're talking huge amounts of the health budget. So we really need to stop people from developing these things so that they don't have all of these problems, and society doesn't face all of these costs, not only from having to sort of fund treatment, but also from people being missing from the workforce and being able to contribute to society. So let me tell you a little bit about decision making, and then I'll explain why I think it's relevant for eating disorders. Well, decision making is an executive functioning skill. And it's related to having to select adaptive or advantageous thoughts or actions. And the neural correlates are the ventral medial prefrontal cortex and the ventral striatum. We think that effective decision making follows a sort of J-shaped developmental trajectory. So it seems to kind of decline from late childhood into early adolescence, and then it improves in mid-adolescence and well into our early adulthood. And disadvantageous responses have been observed on experimental tests across many different disorders, not just eating disorders, and other disorders that originate in childhood as well. So it's not sort of just for eating disorders, it's perhaps a kind of transdiagnostic feature. And that's, I think, why computational psychiatry has been really interested in this, and researchers from that field have really spoken about how decision-making differences might really explain lots of different psychiatric disorders, and maybe psychiatric disorders are sort of decision-making problems, perhaps. People are perhaps reasoning differently about the social context, or having biased thinking in a certain way. And this is something that we see across lots of different psychological difficulties. Particularly for eating disorders, we know that people can be very cautious, overly cautious, particularly those that have more restricting illnesses, where they're heavily reducing the amount of nutrition that they take in each day. And this group is also very anxious, and perhaps not very driven and motivated by reward. And they're sort of motivated by wanting to avoid punishment, wanting to avoid getting things wrong. So having these very high levels of loss aversion. And there are also people with eating disorders that are very reward driven and very impulsive. So we do see this quite interesting picture across the different behaviours that people engage in when they have an eating disorder. That might be related to decisions that they're making about food, exercise, and how they, I suppose, how they relate to their body and to nutrition more generally. And contemporary models of eating disorders really do hypothesize that there are differences in decision making, and that potentially these differences might even perpetuate the illness. So some of the neurobiological models speak about how differences in brain development being affected by starvation in adolescence might potentially be a pathway into the illness, and decision-making differences could arise from this. So this is something that we think is important in eating disorders, and it's something that we have been researching. And I'll share a little bit of that in a moment. But first, I want to give you a bit of an insight into decision making from patients' perspectives. So these are two people that I've worked with who've spoken to me about these troubles. So we've got, I can't make decisions at the best of times. And this was a person that really wanted to buy a diary, but never was able to get one because there were just so many factors that they had to take into account, and they sort of became frozen in the decision-making process. I'm scared to choose the wrong option. I get overwhelmed weighing up all the possibilities. Sometimes I just want others to choose for me, but I hate doing that because I want to be in control. If I get something wrong, I feel terrible, and it makes me want to avoid it. I never take risks. I hate doing anything even vaguely risky. And we've got a person here who has sort of other decision-making troubles where they're losing control of their behaviour. When something unexpected happens, all their plans go out of the window and they engage in more risk-taking behaviour around their eating, around their safety, around their finances. They're scared of getting things wrong, so they have that sort of anxiety, the sort of punishment sensitivity. But once that impulsivity kicks in, they're predictably impulsive, and others think they're fun, but for them, they experience it as a bit of a nightmare when they're having to clear up the aftermath of their decisions. So what we know so far about decision-making in eating disorders comes from self-report studies and experimental work. So back in 2010, I did a systematic review. And what we found was that people who had more restricting types of eating disorders, so perhaps what we might say they're sort of anorexia nervosa eating disorders, had very high punishment sensitivity. So they were avoiding risks, avoiding trying, they were driven by wanting to sort of avoid failure. And they weren't really driven by reward. So they had that very low appetitive motivation. And you can see here that people are making very different decisions depending on those sort of sides of their personality. And people with more that engage in more binging and purging sorts of behaviors had high punishment sensitivity as well. So they had that anxiety, that fear of doing things wrong, alongside being very reward driven and being more impulsive. And we also found that this was the same in people who'd recovered. So this might be something that's a kind of trait that sort of is with you. And unfortunately, however, we don't know what the people in these studies were like before their illness. And that's, a problem. And we have done some work to try and look at people sort of, I guess, after their illness. So this study looked at people who engaged in an evidence-based treatment for anorexia nervosa in this case. And we found even after 40 sessions of very intensive psychotherapy, a treatment called Mantra, there were no differences in people's decision-making, in their reward and punishment sensitivity. There was a small improvement in anxiety, which was really good to see, but these things seem to be fairly stable. From the experimental data, we know that on tasks like the Iowa gambling task, where there's sort of risky decks and safe decks, and you have to sort of learn that through the course of the task, and then to do better at the task and get more hypothetical money at the end of it, you learn the strategy of which decks to bet your money on. We find that people with eating disorders don't seem to benefit very well from the feedback that this task gives them. In fact, they score in a range that people with brain injuries score in, and they seem to take different decisions in the face of a sort of reward and punishment signals. And this has also been shown on another experimental task called the game of dice, which doesn't have a learning element like the Iowa gambling task, but has the same sort of premise. And in this case, people with binge eating disorder, so individuals that their main sort of behavior is binge eating, having binges, made more risky decisions, and they didn't use the feedback advantageously like their peers in the other study. So we think that decision making is different in people with a sort of acute eating disorder. We think that potentially it may not change too much over time, But we don't really know about what people were like before before their illness developed, because these studies are cross-sectional. So we don't know whether this is a sort of state or trait thing, or potentially a sort of scar of the illness. Maybe maybe engaging in eating disorder behaviours and the impact of intermittent or chronic starvation on the brain could change your reward networks, and perhaps embed sort of these decision-making differences later into your adulthood. Also, we are very much plagued in the field by small samples, and most of this work focuses on clinical samples. And we know that most people, sadly, with eating disorders aren't in clinics, they're in the community, and may represent a slightly different cohort with a sort of broader continuum of disordered eating and more severe eating disorder symptoms than just those who get into our clinical services. Also, these studies are very much confounded by the fact that people are either very severely underweight or they've experienced chronic starvation, and again, that can have impacts on the brain and people's relationship to perhaps reward and punishment. So we came up with I think, very novel way of tackling this question by exploiting data from the Millenium Cohort Study. And that was what the grant that we applied for and were successful in being funded really wanted researchers to do. The MRC wanted us to come together, eating disorder experts, epidemiology and developmental psychology experts, to really exploit existing data sets. That was one of the parts of the call. So this seemed like a really good way to tackle some of the gaps in the knowledge. And the Millenium Cohort Study is the 4th longitudinal birth cohort study in the UK. It has almost 19,000 people enrolled, and they've been followed up since 2000. And what's really good about this particular cohort is the stratification really tried to ensure that there was adequate representation, not only of the 4 UK countries, but also Black and minority ethnic groups, because this is something that I think past work perhaps has struggled with attrition, and the samples haven't been as representative of the people in our nation. So our aim really was to be the first longitudinal prospective cohort study to investigate how differences in decision making, measured using a task called the Cambridge Gambling Task, at ages 11 and 14, might contribute to the presence of eating disorder symptoms in adolescents at 14 and 17. And a further question that we were interested in, which sort of arose through this collaboration, was whether emotion regulation might also be an important factor. This is also something that's very important in models of eating disorders in terms of maintaining the illness, but also in patient histories, difficulties managing emotions are very important. And often eating disorder behaviours are conceptualised as emotion regulation strategies. So we wanted to understand whether very early emotion regulation, sort of in early childhood, might be related to decision making, might be related to eating disorder symptoms, and whether that relationship might be mediated by decision making in adolescence. So whether that might be part of the pathway. And so let me tell you what we found. So we've been using data from sweeps 2 to 4, 5, 6 and 7. So when the children were 3, 5 and 7, at age 11 when the Cambridge Gambling Task was administered, and at age 14 and age 17 when we first got information about eating disorder behaviours from the sample. So some of our data set contains just 11,303 boys and girls, but when we include the age 17 data, that goes to just shy of 9,000. Let me tell you a bit about this Cambridge Gambling Task. So this is a task from the Cambridge Neuropsychological Test Battery, and it's about measuring decision-making and risk-taking outside of a learning context. So unlike something like the Iowa Gambling Task, participants don't have to learn the kind of contingencies. it has quite a few different outcome variables. It has one on risk taking, it has quality of decision making, it has deliberation time, it has risk adjustment and delay aversion. And I think it's really an interesting task, and it's quite a complex task as well. We can perhaps discuss a little bit more about that later, about whether this is the best measure of decision making, but it was the one available to us in the Millenium Cohort Study. Eating disorder symptoms were measured through self-report items administered to the young people in the Millenium Cohort Study. And we were able to assess quite a few different facets of eating disorders. We haven't got every sort of eating disorder symptom possible, but we've got some of the key ones that the DSM or the ICD include in their diagnostic clinical criteria. We've got body dissatisfaction. So this is people perceiving themselves as being too overweight. We've got an intention to lose weight. So that's a kind of eating disorder cognition. We've got an actual behavior, which is dietary restriction. So that's using reduced dietary intake to influence shape or weight. And we've also got excessive exercise, the use of driven exercise to influence shape or weight. And we've got an objective measure of weight because the young people were weight. And the Millenium Cohort Study uses the UK 90 sort of cut-offs for different percentiles, and this is what we've included in our models. Emotion regulation is measured using the Child Social Behaviour Questionnaire, which is 10 items, and it has two subscales. It has independence and self-regulation and emotion dysregulation. We were particularly interested in the emotion dysregulation subscale, but we included the other one as an interesting comparator. It's more in the kind of cognitive domain of emotion regulation. We controlled for a number of confounders, including gender, ethnicity, poverty, IQ, pubertal status, symptoms of internalizing and externalizing symptoms using the SDQ. And we also controlled for objectively measured exercise activity in some of our models, because a subset of the participants in the study had actually been given accelerometers. So we were also able to see objectively how much activity they were doing alongside their subjective reports of the use of excessive exercise to influence their weight and shape. So let me talk you through what we've learned. So models 1 and 2 relate to whether decision making at age 11 is associated with the presence of eating disorder symptoms, first at age 14, and then as we were able to access the age 17 data, also at age 17. And I'll sort of come back to that model later. I think it sort of explains our sort of research process, because we got the age 17 data later on in the project. Now, what we found was quite interesting. So this is some descriptive data on the sample. We found that body dissatisfaction, so believing that your body was really, really overweight, wasn't necessarily present in the sample at age 14. And I was quite surprised by that, but it might be that actually it's not necessarily a precursor to eating disorder behaviors. It's maybe something that arises from engaging in those behaviors and might sort of emerge a bit later in the trajectory. We found that about roughly, or just shy of half the sample were intending to lose weight, and a similar amount were actually acting on that intention and actively reducing their dietary intake at the different sweeps, at this sweep at age 14. It's about 60% of the sample were engaging in driven exercise to influence their shape and weight. So we can see that these young people are wanting to lose weight, and many of them are trying to do something about it. A small group were underweight, quite a very small amount of the group actually, based on the UK 90 percentiles. And sort of in keeping, I guess, with the general population of the UK, around a third were overweight or obese. So yes, I guess it's interesting, isn't it, that although quite a lot of them were wanting to lose weight and trying to lose weight, it didn't seem like their dietary sort of restriction was achieving perhaps what they were intending. And that could be a whole other talk about how diets don't work, but more of that another time perhaps. So from the final sample, we found that those with better quality of decision making were 34% less likely to show an intention to lose weight. So they were making different decisions about their weight and shape, and 34% less likely to be overweight. Those with higher risk taking were 58% more likely to show dietary restriction. So perhaps slightly more impulsive group, really acting on some of these intentions. And 46% were also more likely to report excessive exercise. When we looked just at the complete cases, we found that higher risk adjustment was associated with a 47% increased risk of being underweight, and better quality of decision making was associated with a 46% lower risk of being overweight. So I think the sort of take-home message there is that there are some differences in decision making in those that present later in adolescence with some of these symptoms, these key symptoms of eating disorders. So I'll come back to model 2, which includes the age 17 data. But before we were able to access that, before it was sort of released to us, we were quite interested in looking at whether at age 14, these symptoms of eating disorders might sort of cluster together in a way. So might it be that people who are, I don't know, restricting and exercising might, that those sort of symptoms might relate to particular differences in decision making, or in other ways, maybe underweight and restriction could sort of cluster together and be related to low risk taking or something like that, as we've sort of seen in the cross-sectional data. So this was a question that we attempted to address by using latent class analysis, and we tried to identify symptom groups within the data set. And we didn't get sort of types of eating disorders. So the best sort of solution, the best fit of the model to the data was actually two groups, one with symptoms and one with sort of no symptoms, essentially. So the sort of high symptom group, what I'm calling the sort of prodromal eating disorder group, they were the ones endorsing an intention to lose weight. They're trying to lose weight. They were more likely to have that body dissatisfaction and be sort of using the sort of exercise, and they had average or above average weight. So these this prodromal eating disorder group, and the prodrome is sort of indicative of the development of an illness. We were able to identify these in the data set, but we couldn't really, our modelling didn't really cluster together symptoms. I mean, perhaps because there aren't, we're limited by the number of symptoms that the MCS has actually measured. But what we did find was that less risk-taking, poorer quality of decision-making, longer deliberation time, and less risk adjustment, mirroring what we found really just looking at the symptoms themselves, were more present in the group that had this prodrome of the eating disorder, and also more internalizing symptoms, which goes with what we know about individuals with eating disorders, that they tend to have this childhood history of depression and, well, of anxiety, really. So far, we know that within the MCS, we can identify an eating disorder prodrome. This group has early symptoms indicative of the onset of an illness. So we've got some useful data already emerging from this data set, and we can see that the longitudinal data are showing us that decision making can potentially be part of the developmental pathway of an eating disorder. So what about at age 17? Were some of these findings sort of sustained across adolescence? Well, very much so. We found that being less good at betting on the most likely outcome, taking less time to decide on which bet to choose, were associated with the prodrome of the eating pathology persisting over adolescence from age 14 to age 17. And similarly, looking at some of the other outcome variables from the Cambridge Gambling Task, deliberation time and delay aversion, we found that a sort of moderate approach under conditions of risk at age 11 and age 14 were then associated with reduced eating pathology. So the likelihood of not being in that eating disorder prodrome group at both age 14 and 17. So we can see longitudinally now that there's this pattern emerging. So decision making seems to be different in those with prodromal eating pathology in adolescence, and this might be a really untapped prevention factor. Decision making is something that can be trained, so maybe it's something that needs to be part of primary prevention, and we can get people being much better at making good decisions for their health so that they're less likely to get into the clutches of an eating disorder later on. We then looked at whether changes in decision-making skills were associated with the later development of these eating disorder symptoms. And what we found was that people in the prodromal eating group, eating pathology group, changed less on one of the Cambridge Gambling Task outcomes, on the risk-taking task. And so their ability to make good decisions under conditions of risk seem to improve more slowly than those that weren't in the prodromal eating symptom group between the ages of 11 and 14. And I think this is really, really interesting because it demonstrates that there may be a potential sort of neurodevelopmental etiology for eating disorders, and it really challenges the belief that is often held by the public that eating disorders are sort of a lifestyle choice, or they're a sort of diet gone wrong, or they're some sort of phase or fad that people kind of try out. You know, this really shows that people might have differences in this cognitive skill that make them more vulnerable, and we can do something about that. But also it's not their fault. And I think when I've shared this with patient and carer groups, they really valued hearing that there was nothing really necessarily that they did. It's just unfortunate that they might have some differences that made them a bit more vulnerable to developing these eating disorders. So the take-home message at this stage is that risk-taking changes less. So advantageous risk-taking changes less on the Cambridge Gambling Task in those with eating disorder, with an eating disorder prodrome between the ages of 11 and 14 compared to the non-prodromal peers. And so helping young people to make more adaptive responses under conditions of risk could be one way that we could sort of steer them away from these behaviours and these intentions early on. So models 5 and 6 look at the emotional regulation component or the emotion regulation factor that could also be part of this puzzle. So we were interested in whether decision making at age 11 might mediate the relationship between emotion regulation at ages 3, 5 and 7, and then eating disorder symptoms at ages 14. And then when we got the age 17 data, we were also able to model this. So that's why we've got 2 publications to report in. So we use latent growth curve models, and we estimated the longitudinal trajectories of emotion regulation from ages 3 to 7. And then we use the individual predicted values of the intercept and the slope. So that told us something about the change in the mediation models. And the individual predicted values of the intercepts and the slopes were used in our regression models, and we are able to test for mediation. And what we found was that the sort of cognitive side of, the more cognitive side of emotion regulation didn't seem to be related very much to prodromal eating pathology, either at age 14 or either at age 17 or at both ages. And actually this clinically, this very much mirrors patient experience, because people often know how to regulate their behavior, but when they get into a difficult emotional state, it can be really challenging for them to actually apply those strategies and to sort of be independent in that context. And so in keeping with that, we found in the sort of emotion dysregulation subscale of that measure that there was an association between the intercept of the emotion regulation subscale and prodromal eating pathology at age 17, not at age 14, and then, sorry, at age 17 only, and at ages 14 and 17. So we've got that sort of trajectory emerging. And really interestingly, these associations were mediated by the quality of decision-making outcome variable from the Cambridge Gambling Task at age 11. We also identified that this same variable at age 14 was a mediator for the eating disorder pathology at age 17 only. And we, of course, controlled in our models for all of those covariates that I mentioned earlier. So the take-home message here, something new that we've learned, is that particularly emotion regulation, the strongest sort of outcome was at age 3, is related to the later presence of prodromal eating pathology at ages 14 and 17. And that relationship seems to be mediated by decision-making skills at age 11. So it might be that we can identify young people who are having troubles regulating their emotions early on, relative to their peers, and that maybe helping them to improve their decision-making skills might be another way that we can make them more robust and resilient to engaging in eating disorder behaviours in their adolescence. So I think the bigger picture of this work is that we have some potential new evidence for a neurodevelopmental etiology of eating disorders, or at least of the prodrome of eating disorders, of disordered eating. We've got some ideas for new prevention targets, and we've really been able to elaborate on the cognitive differences that models of eating disorders suggest are really important in these illnesses. So we've been able to contribute to these models some new findings around decision making, because we've got this brilliant longitudinal data set, which isn't limited by some of the problems that the cross-sectional work has been. And as I've sort of mentioned going along, I've shared this work in various professional contexts at conferences, but also I've taken it to carers support groups and to patient support groups. And the feedback's really been amazing. People have found it so interesting to understand more about the sort of a potential pathway into eating disorders. And it's really resonated with families. They've really given some rich examples of how they've observed decision-making being really troublesome for their loved ones. So there are some caveats, of course. We don't know what happens between the time points at which the sweeps are administered in a longitudinal cohort study like the Millenium Cohort Study. All we know is, we know that at the time points, whether or not those symptoms are there, but we don't know what's going on in between. Also, because we didn't have a say in how these symptoms were measured, it's not sort of ideal maybe from a clinical perspective. However, I do think it's very useful in terms of how these symptoms might be experienced in a large community cohort. And we can sort of see how they also map onto some of the diagnostic features of eating disorders, but we're looking at it in a slightly more flexible way. We also don't know how many people in the cohort went on to become kind of clinical cases or become known to services and actually received a diagnosis of an eating disorder. And I think that would be quite important or quite useful data to have. So what are we going to do next? So Marta and I have been working on an ESRC grant. And what we'd like to try and do is develop some training that we would share with young people through an app, which would actually use gamification to help them learn how to make really good decisions, generally, but particularly in relation to eating, shape and weight and exercise. And we do this with an industry collaborator who would help us to develop the game and an app, and a collaborator at De Montfort, who's a computer scientist and has got real expertise in developing these, what they call serious games. And these are sort of games where you can learn something, as well as presumably also having a bit of fun. Another way I think that we could develop this work would be through computational modelling, and that was something that we had thought about when we were submitting the bid to the MRC. And I know we now have Yo-Yo in our department, so maybe you could be helping us with this. But I think it would be really interesting to actually look at the raw data from the Cambridge Gambling Task and look at maybe how responses actually change over the task when people are experiencing risks and then they're maybe not choosing the right response and they're getting a disadvantage, they've made a disadvantageous response. What do they then go on to do? Because we don't really know that from the outcome variables that the sort of existing way of analysing this task. So I'm going to end here and open up the floor for discussion, and thank you very much. If you want to read a bit more about my work, I've written lots about it on my website, so please scan the QR code to go there. And I also tweet a lot about eating disorders and mental health, and have lots of connections with patients and carers on my social media, so you're welcome to join in the debate there as well. And thank you so much to the MRC that have funded this work.